Good afternoon, everyone. My name is Shannon Kupka. I'm a project manager working with the nursing home teams in New Mexico from Comagine Health. I'd like to welcome you to our half-hour Hot Topics series. These webinars are designed to provide you great ideas on dementia care, behavioral health, and antipsychotic reduction strategies in a 30-minute time frame to accommodate your busy schedules. They are brought to you by the Comagine Health team, formerly Qualis and Health Insight, from Idaho, Nevada, New Mexico, Oregon, Utah, Washington, and sponsored by the New Mexico Healthcare Association and Comagine Health. So we are really excited about today's presenter on behaviors and unmet needs, a deeper dive. Pat Whitacre joined the New Mexico Healthcare Association in 2015, bringing with her an extensive and diversified background in long-term care. For the last 18 years as a registered nurse, Pat had served as Director of Nursing in skilled nursing and assisted living facilities in New Mexico. Additionally, she has served as a corporate and regional nurse, overseeing national clinical operations and performing quality service reviews. She's consistently challenging and encouraging facilities to provide the best quality of care and the best quality of life for all residents. Pat is responsible for research and development of quality initiatives and quality measure training. She's also responsible for oversight and coordination for CMA 1 and 2 classes, which she thoroughly enjoys, as teaching is one of her passions. She's the primary staff liaison for the New Mexico Healthcare Association Regulatory Clinical Committee, addressing facility quality, surveys, and state and federal regulations. Pat is actively involved in clinical and regulatory oversight issues in conjunction with the New Mexico Department of Health and engaged with the Board of Nursing Medication Aid Advisory Committee. Pat, you may get started.
Thank you. Thank you, Shannon and Comagine, for allowing me to present this webinar today. And I'm hopeful that everybody on the call is going to be able to take back some recommendations and tools to your facility and initiate further dialogue concerning resident behaviors and their unmet needs. First of all, I think we need to understand the relationship between behaviors and unmet needs, what these entities are and how they interact with each other. Behavior is a range of actions and mannerisms made by individuals in conjunction with themselves or with their environment, which includes other systems around as well as the physical environment. An unmet need is a need that stems from a decreased ability to communicate a need or want and the decreased ability to provide for oneself. Most of the common unmet needs can pertain to physical discomfort, where there's pain, illness. A resident could be wet, they could be too hot or cold, they could be hungry, thirsty, or fatigued. They may have mental discomfort related to delusions, psychosis, hallucinations, or fear. There may be social contact needs that are unmet, where they need to be touched or speaking with others, need socialization or laughter. Uncomfortable environments can include clutter, too bright a room, or too dim a lighting, creating in too loud of noises, creating chaotic, overstimulating environment. Along with this uncomfortable environment can be the reason that a resident has a lack of hearing aids when they're supposed to have hearing aids on, the batteries aren't working, so they can't hear well, or a resident needs their glasses, they're dirty, they don't have them on, and this can lead to an uncomfortable sensory environment. There's also inadequate level of stimulation like boredom, or you can have a combination of any of the above unmet needs. Any of these unmet needs can lead to various types of behaviors for our residents because they're unable to communicate their needs to us. They're unable to tell us what is wrong with them, that they're uncomfortable, and we can't meet their needs because we can't understand them for the most part, a lot of times when they have severe dementia. This is an unmet needs model that was done by Cohen, Mansfield, and Werner in 1995. And this model basically hypothesized that the majority of unmet needs with our residents occurs mostly because of the environment and care staff. In turn, because they either do not provide for the needs or they do so in a way that does not accommodate one's preferences, habits, and disabilities. So I asked for a facility, what is the level of confidence in your facility in the determination of resident unmet needs? Meaning, does your staff know what an unmet need is? Do they understand that unmet needs of residents, especially demented residents, can lead to behaviors? And that we need to try and find out what those unmet needs are to lower those behaviors and to even lower antipsychotic usage rates. So the difference between a want and a need is that a want is a desire or a wish for. I mean, I can say that I want to have a Ferrari to go to work in the morning, but I have a small compact car that barely gets me to work. I mean, that's a need versus a want. And a need is a requirement because something is essential. And it's essential to quality of life and to quality of care. So does a resident require both wants and needs? And I feel like they do require both, in the fact that when we help someone with their wants, we are increasing customer service, plus we're decreasing behaviors in that realm. And then when we are looking at needs, we're hopefully being able to anticipate at times unmet needs so that a behavior doesn't start or it doesn't escalate. So I think we do need both wants and needs, and we need to meet both of those criteria for our residents. Excuse me. On the left side of the PowerPoint, you'll see a very typical pyramid of Maslow's hierarchy of needs. And again, I think as many of us, especially nurses, know that when basic needs or psychological needs or self-fulfillment needs are not met, then we can anticipate that there's going to be a reaction. And a lot of times with our dementia residents, those reactions are behaviors. They need food and warmth and water and rest. And if they aren't sleeping well, we might see a behavior. They need safety needs. If they're feeling scared or unsafe, then they may break out in a behavior because those needs are not met. On the right side of the PowerPoint, you'll see unmet needs model of problem behaviors. And unmet needs are individualized for each resident, given their lifelong habits and personalities, given their current condition, mental or physical, and given their environment, physical and psychosocial. All these are their individual unmet needs. Behaviors start escalating, or behaviors even start manifesting as a means of fulfilling those needs. The need is not being met, and a behavior is the end result. We might see behaviors as a means of communicating a need. A resident, especially a dementia resident again, may have a word salad vocabulary, and in their minds, they're saying what they need, but it's coming out as something that we can't, it's garbled and we don't understand it. And they get very frustrated because they're not understanding why we're not taking care of their need or taking care of something that they want at the time. Then we can see behaviors as an outcome of frustration and other negative effects because these unmet needs are not being taken care of. So basically, that's why we need to look at behaviors as unmet needs. How can you assist or anticipate unmet needs of your residents if you don't know what the residents' needs are to begin with? And I stress that because I don't know how we can do that. It's difficult enough to look at the needs of the resident, but if we don't know who this resident was, what their habits were, what their private lifestyles were before they came into our facilities, how are we going to meet their needs and lower their behaviors? We're going to be looking in a few slides at a tool that's going to help staff to identify resident needs and wants and get to know residents on a personal, informed level so that we can begin to try and deal with some of these needs. If you've got a resident that is displaying vocal or verbal behaviors, we need to look at pain or discomfort. One of the very huge issues with behaviors is that we've got a resident that's in pain and they're hurting. And yet sometimes we are using that 1 to 10 pain scale for a resident, even with mild dementia, who cannot tell us what their pain is on a regular pain scale. So we need to make sure that the facilities are using either the pain ad or the Baker Wong face pain scales. And I can tell you that surveyors are looking at this. They're asking nurses, what kind of pain scale are you using? And the staff needs to know what we're doing and how we're coming to a conclusion of how much pain these residents are in. When they're in pain, they're not feeling well. They're hurting, they can push back at us, they can be really upset, and they can be very vocal and verbal. We need to look at loneliness and fear. There may have been a recent death in the family, a fear of abandonment. These residents may have only been in the facility for a couple of weeks. They are confused because they don't know where they are. Their routines have been disrupted, and routines being disrupted is very evident in behaviors for some of our dementia residents. We want to look at depression. And as part of the staff competencies with facility assessments, we really need to make sure our clinical staff, our CNAs, and even our all staff members through staff meetings, that make sure that some of them know even the slightest symptoms of depression, so that they may be able to identify that this resident is depressed and let the nurse know, or let the staff, charge nurse know. Sometimes symptoms of depression are reported not just by the clinical staff, but by dietary, or by the maintenance man who went to go see the resident, or by the activities person that's spending time with the resident. So we need to make sure that they know the symptoms of depression and are able to report it. Then we want to look at boredom too. If these residents are not engaged in anything, if they're isolating themselves, boredom can present as vocal and verbal behaviors. If you've got a resident who's physically non-aggressive, you might need to look at the activity or stimulation of the resident and make sure that they are engaged in appropriate activities, and not always current events. Sometimes a resident will hear a word like war, which can trigger a behavior. They can also see that there's been a plane crash, and they can worry that their loved ones were on the plane and start to be anxious and perseverate on it. So we need to be careful when we're looking at current events with our demented residents, that it's not too overstimulating for them. If there are aggressive behaviors, we need to look at evasion of discomfort, because like I said before, discomfort is huge in residents displaying behaviors. If they're wet or hungry or tired, cold, hot, fatigued, sick, or in pain, they may be having behaviors. We need to attempt to communicate their needs. We have to be patient. We don't want to play charades like, what is that? How you do? Say that again. What are you trying to say? I'm not sure what you're saying. Sometimes that can get them very agitated. So you want to watch for nonverbal communication that the resident may be displaying. We have to be careful also about personal space, because some residents have very limited personal spaces of like 3 and 4 inches. Some of them have 2 and 3 feet. Don't get near them because they feel that their space has been invaded. So we need to be careful with personal space and identify that. I'd like to know how many of the facilities that are on the call have any kind of resident preference form or resident summary form, some way of being able to obtain information about how the resident was before they came into the facility, what their preferences are, what their dislikes are, what are some of the things that they did before they came to the facility, what are some things they like and they don't like. And if you do have some sort of process for that, who's collecting the resident information? Do you obtain information from a family member, from the resident themselves if they have mild dementia, from family friends? And is this form a part of your admissions process? I think that residents that don't have dementia also benefit from having some kind of resident preference form, or some kind of way of getting the information, because they can get frustrated too with what's going on around them, and when their wants and their expectations aren't met, then I think they can also have problems of feeling anxious, getting depressed, and things like that. How would your facility disseminate resident information to all the staff, and where would information be available if you were able to have this resident summary form? And again, we'll talk about a tool in just a few minutes. You can put some of this information on a computer share drive to where it's available to all staff at the facility at all times, because people don't just have behaviors during the day. They can have behaviors at night, they can sundown, they can have behaviors at 2 o'clock in the morning. So information about this resident that might help us to work with their behaviors needs to be accessible at all times. And you can put some of this information in just a binder that would be accessible to everyone in a certain location. And then who would be responsible to ensure that the information is up to date? People change. So somebody might like spaghetti, and then all of a sudden, 10 years later, they hate spaghetti and they don't ever want to have it again. And if we try to serve them spaghetti, they get very upset. So we need to make sure that this information is fluid and that it is interchangeable and that we can update it at any time. Any of the staff can do that too. This is an example of a resident information summary. It's a template. If anybody would like this, please put your emails on chat and I can send this to you. You are, just feel free to delete from this summary, to add to this summary. It's just things that over the years, important questions I think that help staff out to determine how they're gonna go about trying to help behaviors. There are things like favorite foods and dislikes in foods, former occupations, questions about native language, because some residents will speak a language and then when they get very fatigued or when they get overwhelmed, they will speak in their native language. So it's kind of important to know that. Their resident faith, their shower times, important health conditions, who are family members that come and visit these residents. How does a resident prepare for bed? Sometimes we have residents that just like to go to bed in their underwear. And we're sitting here trying to put full pajamas on these residents and they're acting out and having a behavior and we wonder why. Well, we don't know how they like to go to bed, or maybe just the night, one of the night nurses or one of the night CNAs knows that they like a particular way to go to bed, but nobody else knows that. That's why these summaries are so important and that this information is shared with everyone. There are questions about do they have pain history, what helps their pain, and there's very pertinent questions about like when their resident is irritated, what calms them down, and what triggers a resident behavior. So again, these are just very vital information points that we need to make sure that our staff knows completely. The last question I have on this summary is, please give the staff 2 suggestions that would make the resident happy during their stay. So if they're not a long stay resident, they're coming in for rehab and they're leaving. This is really great to know, not only to help with customer service, but it helps family members to feel like we know a little bit about our residents and that we're really trying to make their stay as nice as possible. It could be something like, I need coffee every morning in a porcelain cup and don't try to serve me anything in a styrofoam cup. Or I like a paper in the morning, or something just very simple and basic, but it's something that is important to the resident. And it's something that resonates with them when we reach out and do something for them that makes them feel good or makes them feel at home. So I think that the question would be very apropos for our dementia residents, but it would be great also for looking at customer service aspects. If you'll turn back to that slide again, I'm sorry. There's also room for additional changes. And again, like I said, this is a living, breathing document. So we need to add when a resident is not liking something anymore, or when a resident is wanting something that we haven't identified yet. We can also take a look at changes like the way, again, how they sleep and how now they don't want showers in the morning anymore, they want showers in the evening. We need to be able to make sure that this document continues and we're able to identify again what they no longer like and what we need to start implementing in the future for them. So please, like I said, let me know if you want any more information on this summary sheet. I can get back in touch with you personally and we can discuss it even further. When we're looking at non-pharmacological approaches to resident behaviors, we need to assess the problem, not just the problem, but the behavior. And we all need to sit down with a mixed team effort, an IDT, including dietary, housekeeping, administrative staff, maintenance, instead of just the clinical staff, because we need to make sure that we are getting viewpoints from everyone. The dietary may know something that the clinical staff doesn't know. The maintenance man and housekeeping staff may know something that clinical doesn't know. So we need to sit down and make it a team effort. Hypothesizing the cause is something that I know a lot of facilities do through root cause analysis, and that can be done through fishbone diagrams. It can be done through the 5 whys. It doesn't matter which method you use, it's just coming to a conclusion of why there is a behavior and what is contributing to the behaviors. You want to analyze treatment options. You want to look at non-pharmacological approaches, of course. You want to look at, are there any physiological problems going on with the resident? You want to look at labs, medication reviews. And I can tell you that, for instance, there is medication for Alzheimer's, and these medications are cholinergics. And a side effect of cholinergics that is very common is that they relax smooth muscle, and the bladder is a smooth muscle. So these residents that are demented may all of a sudden get on a cholinergic drug for Alzheimer's, and then they're incontinent because of the drug side effect. This can really cause some behaviors because they don't understand why they're incontinent. They're trying to tell you they need to go to the restroom, and they're not able to communicate that. So you may see some really extended behaviors at that time when this is evident. So we need to look at medication review. And then you need to look at your resident preference summary. Are we doing things? Are we looking at things that we can meet needs so that resident behaviors don't start or they don't escalate? Then you want to treat and keep trying. Some residents are more challenging than others. You may find something very quickly that is easily distracting for a resident, and it gets rid of a behavior. But then there's some residents that you keep trying everything you can, and you're still not getting anywhere with the treatment or your non-pharmacological options. So just assess. Just keep trying to do different things, and also don't forget to reach out to the medical directors, to psychological support, and psychiatrists even that may be doing or treating other residents and reach out for help when you might need to look at some other options. We can assess and try and manage comfort, again, for non-pharmacological approaches for behaviors. We can make sure that the resident is comfortable, that the resident's position is okay. If they're leaning against their wheelchair, we just want to make sure we put a pillow under an arm or something and make sure that these residents are comfortable. Also, when a resident is in a wheelchair, we want to look and make sure that they have appropriate cushioning underneath the wheelchair so that we want to prevent pressure ulcers, but we also want to make the resident comfortable. I don't know if any of you have ever tried to sit on a wheelchair for any length of time. If there's no padding and stuff, it's excruciating. We want to offer food and fluids. This is just part of helping that hydration and hunger, part of unmet needs. Sometimes a resident will get up from the table, we sit them down, they get back up, we sit them back down, and they get frustrated and they get irritated. So walk around foods are excellent. French toast sticks, veggies, sandwiches, anything that you can put in their hand and let them feel free to walk around, that's very helpful. We can provide one-on-one social interactions and music based on their preferences. We can offer walks outside. Outside is, getting sunshine and things like that can be very beneficial for our residents, as we all know. We can offer program for walking and gentle exercises. On YouTube, they have exercises for residents in walkers, and it looks like a lot of fun. We can play DVDs and use memory sticks provided by family when we have residents who become irritated or start displaying behaviors. We can Skype and Facebook. I mean, there's so much technology anymore that we can have our residents reach out to our families that don't live in town or don't live close by. And this really helps to increase socialization skills and laughter. I mean, our residents need to laugh, and they need to look at memories that make them feel familiar and happy. We can introduce or use redirective stimuli, again, like music of their own choice, conversations with staff and family, and touch. And when I talk about touch, we can look at hand massages. I think a lot of times residents aren't touched, and they miss touch. They miss just having somebody hold their hand or massage their hands with lotion or just pat their shoulder. I know some facilities have massage therapists that are students come in once a month, and the residents get chair massages. And so it's massage to the upper back, to the shoulder, to the neck, and just that intimacy of just being touched is really beneficial for a lot of our residents, and it really can calm some behaviors. But we also need to know the residents that don't like to be touched, because there are some of them. To ensuring staff knowledge and training supports for the information of the resident summary, we want to determine the need to educate staff on a process on ongoing identification of needs and preferences of the resident. Those resident summary sheets are excellent information for the facility assessment, for the MDS coordinator to be able to provide resident-centered care plans. Families can use those summaries. Volunteers can use them. Hospice nurses that come in and provide care, it would be useful and beneficial for them to have that information. Staff competencies that are identified by the facility assessments, including knowing the resident preferences, can absolutely have initiate better outcomes for our residents in following through with interventions. And so I want to ask you again, can your staff adequately initiate a response or an action to a resident unmet need? And when you determine that you have the information on this resident and that you know a lot more about them, those responses and actions from the staff will be much easier to manifest. I suggest that at monthly staff meetings, you might want to look at choosing one resident summary and use it for dialogue, for detailed discussion, and get input from all staff members about what you're doing at the time, what you could be doing to make behaviors better, and how the team can all work together to keep those behaviors down and meet those needs. By monitoring and identifying any processes, or like I said, the resident summary information related to unmet needs, when you come up with a monitoring system or identification, it can really be a great CWAPI project. You can aim towards the goal of decreasing antipsychotic medication use by determining which behaviors are unmet needs, and then you can improve your quality measures in your facility. And what I recommend is starting with just a few residents at a time, especially if a resident is behaviorally complex, and then you can add on as you choose to. But you can talk about what interventions were used, did they work, and how were these interventions sustained. It's a great project, and again, you will most likely see some movement in your antipsychotic medication usage being lowered when you are able to identify unmet needs so that the behaviors are not started in the beginning. We have some really good dementia care training resources, and I would love for each one of you to get on every one of these links. It's great resources and training, and the first is the CMS hand-in-hand training, and it's the training has been updated within the last year and a half, I believe, and it's tailored to CNA training annual requirements. For CNAs, it's got a DVD and 5 modules. It's all online. It's a great source of training for your CNAs. The National Nursing Home Quality Improvement Campaign has best practices and strategies for dementia care, including the initiative's question and answer tips. It's, again, another excellent resource for dementia care. Our half-hour hot topics are still archived on the healthcareinsight.org link, and if you click under the antipsychotic link, you get a lot of webinars already that we have done related to caring for residents with behavioral health conditions and concerns and decreasing antipsychotic medication use. So those are very beneficial resources. The other resources we have are concerned with person-centered care. There's an antipsychotic reduction toolkit, again on healthinsight.org, that has materials on identification and management of behavior expressions of distress among residents in dementia. With dementia, it's great resources. The Let's Get Real being person-centered in a task-oriented world is also a really good free online training, and it uses a track concept of tune in, relate, assist autonomy, collaborate, and know the person. The last one is the National Nursing Home Quality Improvement Campaign again, and they have person-centered care, dementia care, and psychotropic medication goals. They have a variety of resources and clinical tools to assist the nursing homes in providing person-centered care. And I wanted to kind of end with a story about someone who had behaviors and how we looked at unmet needs for this particular resident. We had a resident that came into our facility, and he was there for 4 days. And on the morning of the 4th day, the nurse called me at home very early, and she said, we need to talk to the doctor about getting this person on some kind of medication. He is very aggressive. He is lashing out at us. He's trying to hit us. He's cussing at us. He's very inappropriate, and it's getting worse every single morning. So I got into the office, and the staff told me what they were doing, that he was getting up at 4 in the morning. They were trying to put him back to bed, that he was walking around. They tried to give him a shower later in the day, like around 7:30 or 8 in the morning, and he was resistant to showering. He was upset with his meals. He would throw the meals and push them away. At 7:30 in the morning, 8 o'clock in the morning, 9 o'clock in the morning, they would try again. So I called the family. And I told him, I said, you know, your dad's just had a really rough couple of days in the morning, and he's having some behaviors. And I just want to know, can you tell me a little bit about your dad? And so the daughter proceeded to tell me that her father was a mailman for 45 years. And every single morning, her father got up at 4 o'clock in the morning, that he would shower, and that he would eat his breakfast, and he would be on the way with his day. So I took this information and we sat down as a team to discuss what we were doing with this resident. And sadly, we were triggering so many of his behaviors because we were not meeting this gentleman's needs. So we decided that we would go ahead and let him get up at 4 o'clock in the morning, let him go to bed early because he got up so early. We had his breakfast made, and it was ready in the refrigerator for him to have at 4:45. And then we gave him his shower very, very early in the morning also. Everything was done by about 5:15 every single morning. We never had a problem with the gentleman again. There were no more behaviors because, see, we were triggering the behaviors because we were not meeting his needs. And we didn't know his needs to begin with. So again, I think with these resident summaries, we have a heads up on getting to know these residents beforehand, and looking at what it is that they need and want, and not building it around what our schedules are in the facility or what we need to do for staff. It's all about residents, and it's all about resident care. So again, please contact me. I'll be more than happy to speak with any of you about any of the information that we presented today. And you all have a great day. The last thing I wanted to say, actually, I'm sorry, is let's begin to look at our residents as human beings with needs and not as patients with problems. We perseverate on problems when we need to look and perseverate on needs.
Okay, thank you, Pat. I'm going to give everybody a couple seconds to formulate any questions you have. We weren't going to let you say goodbye without a couple of questions or just some comments from our group here today. We had a couple of people mention regarding resident preferences.
Yes.
Caitlin's mentioned the social worker collects this type of information at admission. It's put in the resident's care plan, and all clinical staff have access to this information. Another person mentioned Activities has a form with questions and references, but they just noted that they're worried it's only being used on their residents that have some cognition intact, but
Okay.
that it's a form available through PCC. And then we had Skitch that shared that hospice respite is another short stay in a SNF where the resident information summary could be useful.
Yes, absolutely. And I just want to talk a little bit about, we do have resident preferences on our care plans because our care plans need to be resident centered. But how many people in the facility pick up a care plan? I mean, honestly. And I think that's the dialogue we need to be having, is if they're not looking at care plans, which many of them aren't because they're 15, 20, 30 pages long sometimes. How can you get that information in a very compact way, easily accessible to everyone in the facility? I think that would be the challenge and a dialogue that everybody should be having. Not that it's just in the activities, that it's gathered by activities and put in the MDS, but what activities gathers that is really pertinent information and it's relevant. So how are you going to make sure that it's easily accessible with the whole staff?
Thanks, Pat. And I want to share that the picture of the person, my directions for quality living form that we had on the previous slide, one of our teams actually had taken that and used that for pre-care plan meetings where they would ask family members or the resident to fill out things like, how do I like to start my day? How do I like to go to bed, et cetera. Some of those, that
Right.
same pertinent information, but to make it something that was usable and that the care team had heard directly from the resident and the family in expressing their preferences.
Yeah, and that's another great tool. I mean, you don't have to use my tool. It's just that I just put it out there so that you guys can start somewhere and have a point of getting this implemented in your facilities. We used to do this 10 years ago when we did resident-centered care and we looked at culture change and things like that. And I think over the years through turnover and different, lots of different positions and people being in different positions, we kind of lost track and we lost that that ability or the tool to get that information. So we're trying to bring it about again, and I think it's just pertinent. I know that sometimes facilities may say, well, that form takes a while to get, that information takes a little while to get, it's kind of time consuming, but I guarantee you it's more time consuming dealing with behaviors and having to do one-on-one assistance with behaviors than getting to know this resident and knowing what it is that triggers their behaviors and what we can do to calm behaviors.
Great, thank you. So I just wanted to note that Jessica mentioned in PCC there's a Cardex option that has a Cliff Notes version of the care plan with specific areas for personal preference and is available to floor staff on their care logs. Also wanted to mention just a couple of things because I know folks need to get back to their day, and thank you those of you who are hanging on.
Yes.
Jeff thanked you for the story about the mailman, and Skitch mentioned that on YouTube he had shared a link on the Tellington touch technique with persons with dementia.
Excellent.
And also that photos on the internet of where the resident grew up, lived in adulthood, et cetera, that some folks copy them to a Word doc and print that out for residents.
Right.
Okay.
Thank you for the input.
You bet. And thank you. I want to let everybody get back to your day, so I'm going to give you about just another 10 seconds if there's any burning questions you have. And while you're formulating that, like to mention that the presentation will be posted to our website in a few weeks, and I encourage you to check out all of our posted webinars there on our nursing home library. I've put the link into chat, so please share this with any of your colleagues who couldn't attend today, or consider using portions of these trainings to in-service your staff. For CEs, again, New Mexico teams, please enter the name and email of any attendees in chat so we can send you a test link. And please also join us on May 17th for our next hot topic on reducing neuroleptic use in long-term care, working as a team with Dr. Harry Krulowich. So, seeing no other questions, but a lot of thanks for your presentation, Pat. I'd like to thank our presenter, Pat Whitacre, for coming in and doing a great job today and also filling in with kind of short notice. So thank you very much. I so appreciate you.
You're welcome.
Thank you, everyone. Appreciate you being here for Hot Topics. This ends our session for today. So thank you, and please have a wonderful weekend. We'll see you at the next session.